3, 2, 1, please start.
Good evening, friends. Welcome to the Thursday evening webinar series, and we are today entering into the 39th webinar of the PG track program. And we have had a variety of lectures, and we have heard different perspectives on the same disease from different experts across the country. And today we have the privilege of having Dr. V.S. Narain, who will be speaking to us on cyanotic congenital heart disease. It comes both as a long case, short case. It is often asked in discussions, and it is one of the most intriguing and one of the most challenging cases, and a must case probably for every fellow and resident to clear or get that degree of DM cardiology or DM cardiology. So today we have along with us on this journey Dr. Sumod Kurian, who is professor of cardiology, my colleague Dr. Girish MP, professor of cardiology, my colleague Dr. Arima Nigam, who is associate professor of cardiology, and over to you, Dr. Sumod, to welcome sir. And if you have any questions and comments and clarifications, we'll be going slow in this particular session. We have requested sir to split it into different sessions so that you can have a deeper understanding that how to actually approach rather than just mugging up what are the differential diagnosis and everything. So just be with the flow, just understand how the things are working, how the things take shape. And if you have comments, suggestions, and questions, please write in the chat box. We'll be very happy to answer all the questions in the end. So over to you, Dr. Sumod.
Once again, a very warm welcome to today's PG Track program. Dr. Narain sir doesn't need any introduction. Sir has been the head of the department at KGMC Lucknow. We already had a very beautiful lecture from sir on the chest X-ray interpretation in congenital heart disease, and we all thoroughly enjoyed that lecture. And today we have another important topic, which is approach to cyanotic congenital heart disease. What makes this special is that sir is a person with great clinic, not only with great clinic experience, but a great teacher, and has been examiner in a number of exams. So sir will be the appropriate person to give the good tips, not only for your exams and for your daily clinical practice. And where all one can go wrong when we are presenting cases, all this thing, a great examiner like sir can only teach us. So please, welcome sir. We all welcome sir. Please come and teach us on this session on cyanotic heart disease.
Thank you very much, everybody, Dr. Mohit, Dr. Girish, Dr. Subodh, Dr. Nigam, and to all the candidates who are due to appear in the DM examination. So I think this is an important case discussion, but this is basically a very theoretical sort of case discussion most of the times, and I will come to that. But let us revise through what we have learned over the years and from our peers and from our seniors and from the stalwarts. So let me begin with sort of remembering Dr. Rajan Tandon, who has been the father of pediatric cardiology in the country. And he was the one who has taught us all through, and this little book, which seems little, but it is so full of knowledge, and this is what we have read, and it has helped us so much in understanding congenital heart disease. And I recommend that this book should be read by all PG students. So my homage to Dr. Tandon, and despite the fact that he was such an excellent clinician, he said that auscultation is a very soft data, and it heavily depends on personal observation and clinical practice. And the more patients you keep on examining, the better you become as far as the interpretation and observation of auscultatory findings is concerned. And it says that do not go just by your auscultatory findings. Try to depend on the other associated findings also, because that will help you in getting to the best diagnosis at hand. So just don't go by auscultation. And he said that observation is more important. And once you make the correct observations, then your interpretation should come. If you go with a bias in your mind about a particular diagnosis, then you try to manipulate your auscultatory findings in the same manner. And that perhaps sometimes, leads you into trouble. So be very observant, be very careful in your observations, record them well, and then interpret them. And the more you do, the more examinations and interpretation observations you do, the more skills you will have. But remember that it is always a very soft data, the clinical examination part, and then there are other things such as the ECG, the X-ray, and now you have so many other investigations besides echo, the CT and the MR. So everything will help you in the diagnosis. But yes, for the examination, you have to develop on your clinical skills and present it well to the examiner. And Professor Rajan Tandon, whom I have already said is the father of pediatric cardiology in India, he specifically mentions this, that whenever we go about trying to understand cyanotic heart disease, we must understand that the degree of cyanosis in a particular patient does not depend upon the anatomy. It does not depend upon the amount of mixing and in what chamber it is mixing. It depends mostly on the degree of pulmonary blood flow. And he gave this wonderful diagram which helps us understand why pulmonary blood flow is important to determine the degree of cyanosis. He goes on to say that unless we have heart failure, the venous return, that is the blue ink by this tap, will remain the same. And the pulmonary veins which give us the red ink will vary from large to normal to reduced. And in this chamber, when you have the mixing of the blue and the pink blood or the red blood, it is not the blue blood which is determining the color of the ultimate output here, nor the mixing chamber. It is the amount of red ink. So the more the red ink, the more redness you will have. The less the red ink, the more blueness you will have. And the red ink, of course, is the blood which comes to us from the pulmonary veins. And the pulmonary veins will get fed from the pulmonary arteries. So the amount of pulmonary blood flow determines the degree of cyanosis. So just remember that whenever you have cyanosis, the more the cyanosis, the less will be the pulmonary blood flow. The lesser the cyanosis, the more will be the pulmonary blood flow. So that is the basic of cyanotic congenital heart disease, and it has to be remembered, and this is how things will gradually develop. So as already said, in the absence of heart failure, the systemic venous return remains normal. If the amount of pulmonary blood flow is large, cyanosis will be mild, and it can be so mild that it can even be missed. And what you think is an acyanotic condition could actually be a cyanotic condition where you're making the cyanosis because you have a good amount of pulmonary blood flow. And sometimes we cannot exclude congenital cyanotic heart disease below the age of 1 year only by the clinical examination. Because I said, if you have a good pulmonary blood flow, you can miss cyanosis and you can pass off this child as having an acyanotic heart disease or no cyanotic heart disease or no heart disease at all. And therefore, the concept of looking at pulse oximetry before you discharge every child, every infant, every neonate which is born and is discharged from the hospital, you must perform a pulse oximetry to see for oxygen saturation and differences in oxygen saturation in the upper and lower limbs, if there are any. And sometimes when you suspect the patient to have heart disease and you find that there is no cyanosis, an X-ray which shows an absence of the thymus could lead you to suspect that this patient probably has cyanosis, because in a cyanotic heart disease, the thymus tends to disappear. Otherwise, in an infant, you expect that the thymic shadow will be there, but if it is absent and you suspect some kind of heart disease and you're not sure of the cyanosis being present or not, look at the thymus, and that might lead to the diagnosis. So these are the little things that can often be asked in the examination, and you should know. Then my respects also go to Professor Savitri Srivastava, who was a student of Professor Rajan Tandon, and she was the one who really generated an interest in me on pediatric cardiology, and then she sponsored, not sponsored, I would say, but she sent me with a letter of recommendation to Dr. Jim Locke at the Children's Hospital, Boston, where I spent some time, and then my interest in pediatric cardiology was built over there. So my respects to Professor Savitri Srivastava. And then my peers, my friends and peers, Dr. Anita Saxena from AIMS, Dr. Kothari from AIMS, and Dr. Vijay Lakshmi. I must say that she is a couple of years senior to me, but this lady has so much to teach us, and I'm sure A lot of our students would have learned so much from her. And his book, which we keep on reading and which we'll discuss subsequently. And then lastly, my junior colleagues, my friends, Dr. Radhakrishnan, who was here with me at the Sanjay Gandhi Institute of Cardiology, Institute of Medical Sciences there in Lucknow. And then he moved on to Escorts in Delhi. And now he is the one whom I look up to every time I have a problem with congenital heart disease. I always give him a call and take his advice as to what is to be done. So wonderful person, wonderful teacher. And I'm sure you guys also must have listened to him and must have learned. And then the smiling face, ever smiling face, Dr. Rama. He did his MD medicine from here at KGMC, and such a wonderful guy. And he is the one who is really taking this pediatric cardiology forward with his younger colleagues. So my respects to all my seniors, my peers, and my colleagues. And then, of course, the greatest teachers of us all, for us all, are our patients who keep on teaching us as to the newer things that keep on coming as in every case is a challenge, and every case has so much to teach everybody. So my debt to all my patients. And there are certain books I would say that one must read. One has to clear, and one does not need to be so sort of diligent. But yes, some of the books that you must read, besides the one which I already said by Professor Rajan Tandon, is this great book of Congenital Heart Disease by my senior of a couple of years, Dr. Vijay Lakshmi, and this grand old lady of cardiology whom we lost some time back, Dr. Padmavati. I mean, wonderful lady. She's the one who brought cardiology to India, and Dr. Vijay Lakshmi this book. So I must recommend that this book is to be read by all the students of cardiology who are appearing for the NDM examination. And then this book by Dr. Ramakrishnan and Dr. Jacob Jules, who has been my co-examiner in many exams at the AIMS. Wonderful clinician, so many books he has written. But this small little book of clinical methods is also a must for all PG students. A very concise book which gives us so much information in such little space. And for the exam going people, this is a gem of a book, and I recommend that it must be read by all. So these are my recommendations as far as books are concerned. So now to the examination, and the first thing is that never be afraid of your examiners, because most of the times they know little about the case, and perhaps you are more informed about the case than they are. And sometimes I say that when I go to take an examination, I tell the students that you know more about the case than me, and in fact the examination is I am being examined in this case rather than you, because you probably have a lot of information which I don't have from your friends and colleagues. So don't be afraid of the examiners. But yes, of course, you are on the wrong side of the table, so be prepared to be insulted at times. Now things have changed and we don't do that anymore, but some of the older examiners and some of the newer ones also have this tendency to sort of make light of the examination at times. So be ready to be insulted also, not all the time, but some of the times. And you have all types of examiners, the very serious ones, the very funny ones, the very light ones. So be prepared for all types of examiners. And and we don't be afraid of them. That is what I need to say. But sometimes you can be lucky and you can get this type of examiner, and things will become much easier. But from the lighter side, let's go on to say that don't be intimidated neither by your examiner nor by the case, because it is a very happy situation. Why? Because congenital heart disease is so easy. Physical signs are hardly any, they're very minimal. It's just a murmur here and there, and you have second heart sound which you need to interpret. And the discussion in the case has to be, more or less will be theoretical. And most of the questions that are going to be asked, you already know, and you know the answers of those beforehand. So mostly a theoretical discussion. So don't be intimidated, be well prepared by, so you are well prepared to answer all the questions, which probably are the ones that will be asked. Though the bigger question is, why in the world would one, like to face as far as clinical examination is concerned, because you already have an X-ray ECG and you also have echocardiography. So why spend so much time of clinical examination when you have echo to get to the diagnosis in 5 minutes time? And the answer is that you have to clear the examination, and the examiner wants to know your application of mind, your interpretation of clinical signs is important, but more than that, he wants to know how you apply that knowledge, your knowledge of cardiology, the theoretical background, your experience, as to get to the diagnosis. So, to my mind, the diagnosis in a congenital heart disease is not so important, as the examiner wants to know how you're able to interpret your findings and how you're able to apply your mind to get to that diagnosis, whether right or wrong, that is a different issue, because ultimately you have echo which will clinch the diagnosis. So let's get on with it. So cyanotic heart disease can be classified. Everybody knows this classification, but there are certain points that we will emphasize. You have the without pulmonic stenosis, with pulmonary stenosis, with pulmonary stenosis, you have TOF and you have triology. Without PS, you have the transposition physiology, and you have the admixture physiology, which we will discuss. With pulmonary arterial hypertension, you have Eisenmenger, and you have that with pulmonary vascular, pulmonary arterial hypertension, secondary to pulmonary venous hypertension. This is also an important group. And the two conditions which cause this are the hypoplastic left heart syndrome and the total anomalous pulmonary venous connection with the obstruction on the common vein. So these are the two things we shall discuss, and then you have a situation which is miscellaneous, where you have the Epstein's anomaly, a pulmonary AV fistula, and SVC draining into the left atrium. So cyanotic heart disease classified like this. And tetralogy and Eisenmenger perhaps mimic each other physiologically. The only difference is the site of resistance. In tetralogy of Fellow, the resistance is at the pulmonary valve or below the pulmonary valve. And in Eisenmenger, it is at the vasculature, that is in the distal vasculature. But they're all basically reduction or resistance to pulmonary blood flow. And this is the physiological mimicking between tetralogy and Eisenmenger. Tetralogy is with PS, Eisenmenger is with PH, that is distal obstruction. So let's look at what the admixture physiology is concerned. I am going a little slow because I've been told that you can divide the whole lecture into two parts. So we'll go a little slow and discuss all the little points that might be asked in the examination, because initially I said that most of the cyanotic heart disease is the theoretical discussion. So somebody can ask you what an admixture physiology is. So admixture lesions are those lesions where you have simple mixing of arterial and venous blood, either in the atrium or the ventricle or the great vessel, but there is no obstruction to the flow, neither at the level of the valve, below the valve, or at the level of the periphery in the pulmonary vascular. So there is no obstruction of the RVOT or increased PVR, and there is a simple mixing of. So this is an admixture lesion. And this, obviously, when there is no obstruction and you have great mixing, then you will have an increased pulmonary blood flow. So technically, when you have increased pulmonary blood flow, it is a left to right shunt. Now, technically, it is a left to right shunt where you have increased pulmonary blood flow, but still you have cyanosis because there is some kind of mixing going on. And these are what admixture lesions are all about. And what are these admixture lesions? You have a single ventricle where mixing is occurring. You have the common atrium where mixing is occurring. A truncus arteriosus where you have a common trunk and from where the pulmonary artery is getting out. A double outlet right ventricle where all the mixing occurs in the right ventricle and the blood is circulated to the great vessels. Tomlital anomalous pulmonary venous connection where all the mixing is occurring in the chamber where it is draining. Tricuspid atresia, mitral atresia, mixing is occurring at the atrial level. Pulmonary atresia, hypoplastic left heart syndrome where all the blood gets directed into the right ventricle and from where it is circulated into the pulmonary circuit and through the duct into the aorta. And aortic atresia, hypoplastic left heart. So hypoplastic right heart, hypoplastic left heart, all the atresias and all the mixing chambers are all admixture lesions. So whenever the examiner asks you what an admixture lesion is, be prepared to answer by saying that it is simple mixing without RVOT obstruction or increased PVR, and these are the examples. Now, there are situations where mixing will take place only during systole, such as truncus and double outlet right ventricle. This is obvious that when the ventricle ejects blood into the truncus, it is then that is mixing is going to occur. And similarly, also when the left ventricle throws blood into the right ventricle and the right ventricle mixes, and then during systole it throws blood into the pulmonary artery and aorta. So mixing is occurring in systole. In all the other situations, mixing is occurring all through the cardiac cycle, and therefore the admixture is more complete, such as those with common atrium, tricuspid treasia, and TAV. So this is very obvious that mixing can occur in either systole or through the entire cycle, and these are the situations where this can happen. Now, theoretically, admixture lesions can either be right to left or left to right, because mixing is occurring, can go either way, from left to right or right to left. But net shunt is left to right. The net shunt is left to right. Although the mixing is right to left, left to right, and right to left, but net shunt is left to right. And these are the situations which we have already discussed. And this is the group that we have been traditionally calling cyanosis with increased pulmonary blood flow. Whenever you say we have cyanosis with reduced pulmonary blood flow, and you have cyanosis with increased pulmonary blood flow. So these admixture lesions are traditionally have been called as cyanosis with increased pulmonary blood flow. So remember that they have this commonality, that you have increased pulmonary blood flow left to right net, and then cyanosis because of the mixing. But since increased pulmonary blood flow is there, cyanosis is not as deep as in those cases where you have a reduced pulmonary blood flow. That is in the हेलो जी, हाँ मैं एक लेक्चर ले रहा हूँ अभी, मैं थोड़ी देर बाद आपसे बात कर लूंगा। मैं एक लेक्चर ले रहा हूँ, आप मुझे घंटे भर बाद कॉल कर लीजिएगा। So this is because you have increased pulmonary blood flow. Despite the mixing, cyanosis will not be as deep as you would get in a case of cyanosis because of reduced pulmonary blood flow. So that is the difference. And this is the patients whom we have been calling as cyanosis with increased pulmonary blood flow. Now the question is that if you have such a good mixing, how can cyanosis be minimal? Sometimes it can be so minimal that it can even be missed. Even in a single ventricle, you can miss cyanosis. Now what is the reason? You have a good chamber where all the blood is mixing, but still the cyanosis is not as much. And this is because that you can have a preferential or a favorable streaming. That means the blood which comes to the pulmonary artery is the one which is coming from the systemic circulation, that is from the inferior and superior vena cava, and the one which is going into the aorta is streaming from the left ventricle. So you have a preferential streaming into the aorta and into the pulmonary artery, where the deoxygenated blood is preferentially going into the pulmonary artery and oxygenated blood is preferentially going into the aorta. So this is a preferential or favorable streaming. And this produces a good uninterrupted pulmonary blood flow, and therefore the cyanosis is less intense. Now, question often asked in the examination by some of the examiners is, what about TAPVC? What is unique as far as streaming is concerned in TAPVC? Now you have three types of TAPVCs. One which is below the diaphragm, that is infradiaphragmatic. One which is above the diaphragm, that is supracardiac. And then you have a classical TAPVC which drains into the right atrium. Now what happens with the infradiaphragmatic variety? Now the IVC blood, which is highly saturated because it is coming from the renals, and the renals do not extract that much of oxygen. So the oxygen saturation in the IVC is more saturated than that in the SVC. And this IVC saturated blood preferentially goes into the left atrium. And therefore, when it goes into the left atrium, it reaches the aorta, and this is it is more saturated. In the supracardiac variety, the SVC sends its blood directly into the right ventricle. So the SVC blood goes into the right ventricle, and the right ventricle then throws the blood into the pulmonary artery. Now, both these bloods, whether it is a TAPVC into the IVC or a TAPVC supracardiac, are more saturated because of the pulmonary venous blood. Now, the infradiaphragmatic variety, the highly saturated blood goes into the left atrium, LV, and then into the aorta. So the aortic saturation is high. On the other hand, in the supracardiac variety, the saturated blood streams unfavorably into the RV and goes to the pulmonary artery. So the pulmonary artery saturation is higher. So this is preferential streaming, which is different in the infradiaphragmatic variety vis-a-vis the supracardiac variety. In the supracardiac variety, PS saturation will be high. In the infradiaphragmatic variety, the aortic saturation will be high, and this is the differential streaming which you see in TAPVC. In the classical type of TAPVC, which drains into the RA, there is a balance. There is an equilibrium between PA and aortic saturation. But this is a question that is often asked, and one should be prepared to answer. Preferential streaming and how streaming is different in the different varieties of TAPVC. The infradiaphragmatic, because of preferential streaming, you have higher aortic saturation. In the supracardiac variety, which drains into the SVC, preferential streaming leads to a higher saturation in the pulmonary artery. So remember that. And then you can have a lot of complex combinations, which we're not discussing. Now, as far as streaming is concerned, there are certain situations where streaming will be impossible. And anatomically, you know that once you have a tricuspid atresia, where all the blood is mixing in the right atrium, in the left atrium, where it goes from the right atrium to the left atrium, you cannot have any preferential streaming. So streaming is impossible in a tricuspid atresia situation. So you can have no streaming here. And of course, when you have a common atrium or a TAPVC draining into the RA, which we have already said, streaming is less common. So there are situations where streaming is common, such as double outlet right ventricle, single ventricle. There are situations where streaming is impossible, such as in tricuspid atresia. And there is situation where it is less common, as in common atrium and TAPVC draining into the right atrium. So that much as far as the admixture lesions are concerned. You're not going to get a sick infant. You're not going to get a sick child in the examination. But theoretically, you can always be asked, and one should be prepared with this kind of knowledge that there are situations where you can have a preferential streaming in an admixture lesion, where you can have little cyanosis, more heart failure, and a balanced situation where you can neither have too severe cyanosis or too severe heart failure. So that much. And then there is a situation where, some of the examiners can ask you, okay, what about tetralogy? Is tetralogy of Fallot an admixture lesion? Is it a tetralogy situation where you have reduced pulmonary blood flow? Or is it a situation you can have increased pulmonary blood flow? Or is it an admixture lesion? So the answer is that technically tetralogy of Fallot could be called a admixture lesion if the pulmonary stenosis or the right ventricular obstructive tract is minimal. Now, because there is a large VSD, there is an override, and because there is hardly any resistance, we said admixture lesions where you have mixing and you have no obstruction either at the RVOT level or at the pulmonary vascular level. So if there is hardly any obstruction at the subvalve or valve level on the right side, this large VSD with override could technically behave as an admixture lesion, because this is allowing more blood from the left side to enter the aorta, and this tetralogy of Fallot with minimal pulmonic stenosis or RV auto obstruction could be simply called a ventricular septal defect physiology, admixture physiology, or simply what we refer to as an acyanotic tetralogy or the pink tetralogy. So pink tetralogy is something which has been, not very well understood. And Parlov said that tetralogy can manifest with a left to right shunt with little or absent cyanosis. So pink tetralogy simply means that you have a large ventricular septal defect, very little obstruction to the RV outflow tract. It is an admixture lesion where the net shunt is left to right, and because you have a good pulmonary blood flow, cyanosis is minimal or even absent. So this is as far as the understanding of the pink tetralogy is concerned. So remember, pink tetralogy, large VSD, hardly any pulmonic stenosis, admixture lesion, good pulmonary blood flow, less or even absent cyanosis. And this little bit of discussion on the surgery in admixture lesions. You need to have a PVR which is to be expected to be below 4 units, because if you have more than that, then the results are not going to be favorable. If you have something above 8, then perhaps you should give it a trial of oxygen inhalation and wait for 20 minutes and see if it falls to less than 4, and the QPQS also improves to more than 1.2. So these are some of the points which is universal. Any increase in pulmonary vascular resistance more than 8 perhaps should not be taken. Less than 4, good, results are favorable. Between and 4 and 8, give it a trial of oxygen or nitric oxide and see whether it falls or not. Another question which is often asked and which students always have some problem in defining is, how do you determine shunts in a bidirectional shunt situation? How much is the right to left? How much is the left to right? And then you have the concept of the Q effective flow. So what is Q effective? Q effective pulmonary blood flow is the amount of mixed venous blood going to the lungs without contamination. Left to right shunt means that some blood going to the pulmonary artery is already saturated. And right to left shunt means that some of the blood going into the aorta is unsaturated. And they're equal. And that is the amount of blood which you call Q effective. That is the amount of blood going to the lungs without contamination. And it is calculated by this formula, oxygen consumption divided by pulmonary venous minus mixed venous blood multiplied by 10. Now, once you have calculated Q effective, then the formula for left to right and right to left shunt is given here. And it's easy to remember if you apply a certain sort of formula to it. If you are used to making this diagram where you have the right atrium, right ventricle, pulmonary artery, LA, LV, and the aorta. And when you look at it, on the left side is this left hand is points towards your right atrium, right ventricle, pulmonary artery. And your right hand points towards the aorta. So left hand points towards pulmonary artery on this diagram. So pulmonary artery, aorta. Now, once you see this arm, then this is pulmonary artery. So pulmonary artery flow minus Q effective gives you left to right shunt. And aortic minus Q effective gives you a right to left shunt. So easy to remember. This is how I remember. Pulmonary artery, aorta. Pulmonary artery means left hand, left to right. Right hand, aorta. Aorta minus Q effective gives you right to left. So pulmonary artery minus Q effective gives you left to right shunt. Aorta minus Q effective gives you right to left shunt. And Q effective is oxygen consumption divided by pulmonary venous minus mixed venous blood. And it is the amount of mixed venous blood that goes to the lungs without any contamination. That means it is already saturated. So this is how you calculate left to right and right to left shunt in a bidirectional situation, that is in an admixture region situation, especially in total dominus pulmonary venous connection. So that much for the theoretical background. Let's get back to the examination. Your case will mostly be an adult with reduced pulmonary blood flow. That's what you're likely to get in the examination. And as I said, you're not likely to get a very sick newborn or a neonate. But you must know what a duct-dependent lesion is, that in the neonates and newborns, you must be aware of the duct-dependent lesions. This is often asked in the examination also as to what is a duct-dependent lesion. Now, duct-dependent lesions could be those who have obstruction on the right side and those who have obstruction on the left side and you have transposition of great artery situation. When you have obstruction on the right side, whether it is PS, pulmonary atresia, or Epstein's anomaly, then the PDA diverts partially saturated blood to the lungs. So the PDA helps to provide the lung with blood to improve overall saturation. On the other hand, with obstruction on the left side and in transpositions, the PDA helps in decompressing the right ventricle and gives blood to the systemic circulation to improve the blood pressure and perfusion to the body. So on the right side, it helps to provide more circulation to the pulmonary artery or the pulmonary circulation, and on the right side, it helps to provide circulation to the body and even in decompressing the channel, especially in hypoplastic left heart situations. And what is a hypoplastic left heart situation? If you have a 1-day-old with cyanosis, with heart failure, shock situation, hardly any murmurs, pulmonary venous hypertension on X-ray, you're dealing with a hypoplastic left heart situation. And if you don't treat it, then you're going to lose this patient, this unit in the first month of life. Here, you have complete mixing of blood in one ventricle, and that ventricle is the right ventricle. And that right ventricle has only pulmonary artery as an outlet. And when the pulmonary vascular resistance falls, there is an increase in pulmonary blood flow. All the blood which was there in the on the left side in the left atrium goes to the right atrium, right ventricle, and from there into the pulmonary arteries. And the moment the pulmonary vascular resistance falls, the pulmonary arteries are flooded with blood, and they become volume overloaded. The ventricle becomes volume overloaded. The valvular leaks start happening, and when you have more pulmonary blood flow, that is at the expense of the systemic blood flow. And when you have a fall in the systemic blood flow, you have hypotension, you have acidosis, you have hepatic and renal failures, enterocolitis, and especially if the duct also closes. So the child or the neonate becomes very sick the moment your pulmonary vascular resistance falls and the duct also closes, because duct, as I earlier said, was decompressing your circulation and providing blood to the systemic. And if the duct closes, then all the blood is now flooding the lungs, and none or very little is going to the systemic circulation. So there is heart failure, and there is hypotension and shock and acidosis, renal colitis, renal and hepatic dysfunction, enterocolitis. So the idea is to keep the duct open and don't open it too much. If you open the duct too much, then you will be flooding the pulmonary circulate all the more. So the duct has to be opened reasonably so that you have a balanced QP/QS, so that you have no excessive flow to the lungs, and at the same time you provide circulation with adequate blood pressure so as to perfume the organ. So that is the purpose of managing these patients. And the target here is to maintain a PaO2 or a PCO2 of 35 to 45, maintain saturation in the range of 75 to 80. And whenever you give oxygen, it has to be kept low, because as I said, you need to maintain a good QP/QS. You don't want to increase the pulmonary blood flow so that you have a flooding of the lungs and heart failure, because the more circulation that goes into the pulmonary circulation will be at the expense of the systemic, and that is what you don't want. You want to blood pressure to be maintained, and IV fluids are also to be given 10 ml per kilogram body weight. These are very sick children, and sometimes you may not get any cyanosis which is evident. Why? Because if you have a very low hemoglobin, or if the fetal hemoglobin levels are very high, then cyanosis will not be evident. So the patient will be very sick, will be in a shock situation, but you may not get any cyanosis because of these two reasons: a low hemoglobin and high fetal hemoglobin levels. At the same time, if you have a very high hemoglobin of more than 20, then you can have cyanosis evident even at 85% saturations. Low hemoglobin, even at 70, you might not get an evident cyanosis. So these are all the, I thought that in the first part of this approach to cyanosis, you must, make ourselves aware with the basics. And in the second part, of course, we can go ahead and see the clinical signs, of which you are quite, familiar with. Clinical signs, X-ray, ECG, we can take it in the subsequent next week. So I thought that, certain, basics can be taken up so that at least we know these finer points. One should know the importance of pulse oximetry in these patients. In the infants, you must know, you must have pulse oximetry. It is a must before the patient is discharged from the hospital, because you can miss many congenital heart disease by just your clinical impression. So pulse oximetry, and the moment you get a difference of 3 to 7% between the upper and lower limbs, you are sort of vigilant that this could be a case of cyanotic heart disease. Hyperoxia test, we will discuss that. Prostaglandins, hypercarbia, PDA stenting. You should be aware of the situation where you would like to do PDA stenting. PDA could be kept open with prostaglandins, but beyond a certain point, it may not be possible, and then prostaglandins could have side effects. So PDA stenting is something you must read about. At least at the moment, the level of class of recommendation is 2A and 2B. And then you should also be aware of the hybrid procedures that can be done. Hybrid procedures are done especially in the hypoplastic left heart syndrome, where you, as you said, hypoplastic left heart syndrome, you have to balance flow to the pulmonary circuit and to the systemic circuit. So if there is increased pulmonary blood flow, you have to band the pulmonary artery. You have to keep the duct open. Don't keep it too big. Duct open with a stent, and then create an unrestricted ASD for a mixing of blood, so that all the blood which is there in the left atrium is able to freely go into the right atrium. So this is a hybrid procedure where you band the pulmonary artery, stent the PDA, and create an unrestricted ASD. And so you should be aware of all these procedures. What is the hyperoxia test? Give 100% oxygen for 10 minutes. And if there is no shunting, intracardiac shunting, the PaO2 should go up to more than 300 millimeters in a normal situation. Where you have a lung situation and there is no intracardiac mixing. But if there is an intracardiac mixing, then the PaO2 will not go to more than 550 millimeters of mercury, and there will be no improvement in the saturation. So hyperoxia test is basically, sometimes we will ask as to how to differentiate between cyanosis because of lungs or because of intracardiac shunting, and this is how it is done. Then a question often asked is, how do you give prostaglandin? So you have a vial which is available. It has 500 micrograms per ml, and you dissolve this 1 ml into 49 ml to get a 50 ml solution, and that makes 10 microgram per ml situation. And you start with 0.1 microgram per kilogram per minute, and the duct will generally open up in about half an hour to 2 hours, and then you go to a maintenance dose of 0.05. So this is how you make a PGE1 solution and give it. And you have to be very careful with the heart rate, blood pressure, saturations, and core temperature, because you can have prolonged apnea requiring ventilation. You can have bradycardias, you can have hypothermia, and flushing, and hypotension. So all these are side effects we should be very careful about when you give a PGE1 to keep the PD open. So Dr. Mudit, this was only as part as the basic part of a congenital cyanotic is concerned. So if you have another 15 minutes, then perhaps we can take some part and go ahead and make broader.
Yes, sir, please. It will be great because they will be very eager to listen about the talk and the questions and the mysteries that are asked. So we are very happy to continue for another 15 minutes.
No, but you think it was worthwhile discussing all those?
Yeah,
those
definitely, sir. These are all the things that
because often,
yeah.
So I thought that sometimes you don't get a case, but then these questions are asked. Examiners, sometimes the pediatric cardiologist will ask this, and at least you should know, even if it is not asked in the examination, you should be aware.
Yeah.
Especially the hypercarbia part, which I did not take, but hypercarbia is a methodology of constricting the pulmonary circulation, and it protects the lungs. So a lot of people, instead of trying to do something with the duct, give a carbon dioxide in order to maintain a good circulation by constricting the pulmonary vessels and protecting the lungs. So all these things one must know: how to give prostaglandins, how to do perform a hyperoxia test, and oximetry and hypercarbia situations. Yes, so I thought it is worthwhile taking this. So the idea is that don't be very no particular right from the beginning. Just make a very broad diagnosis, whether it is a tetralogy physiology, that is, or a trialogy physiology, which means reduced pulmonary blood flow, or it is a pulmonary arterial hypertension situation. So just make a broad diagnosis. That's always expected, whether it is a PS, the first thing the examiner, whether it is PS or PH. So make a broad diagnosis. And when we talk of PS, we immediately think of tetralogy physiology. And so it is not tetralogy of fallow, it is tetralogy physiology. And what is tetralogy physiology? Tetralogy physiology simply means that you have a large ventricular septal defect, non-restrictive ventricular septal defect, which allows free mixing of blood. And you have a severe reduction of pulmonary blood flow, whether at the level of the valve or below the valve, or a combination of the two. So this is tetralogy physiology. Now, we've already shown this diagram that in tetralogy physiologies, the amount of pulmonary blood flow determines the amount of cyanosis. So there's no point in repeating that. Now, once we have made a diagnosis of tetralogy physiology, and we think this is a PS situation, and we will come to that subsequently also, we have to see the anatomical equivalents within the tetralogy, and this I have made a mnemonic of 5 TDS. 5 TDS, first T is tetralogy of fallow, second T is D transposition, L transposition, tricuspid atresia, and truncus arteriosus, diminutive pulmonary arteries. So these are the 5 T's, the double outed right ventricle, single ventricle, 5 TDS, and then uncommonly ABCD and some malpositions. But just remember that within tetralogy physiology, you have to differentiate. The anatomical differences would be within these 5 TDS. Now, as far as trialogy physiology is concerned, the mnemonic is PAT, pulmonary atresia, intact ventricular septum, and trialogy of fallow. So in trialogy physiology, you have pulmonary atresia and intact ventricular septum. Trialogy physiology, here the reversal is not through the ventricular septum, it is through the atrial septum. So trialogy physiology is PAT, and tetralogy physiology is VSD-PS is 5 TDS. So easily to remember. Intact ventricular septum, trialogy physiology, ventricular septum, tetralogy physiology, 5 TDS, and PAT. Now, these are the situations where you have the anatomical, this we have already discussed. Tetralogy physiology, D transposition, L transposition, truncus arteriosus, tricuspid atresia, double outed right ventricle, and this is corrected transposition. So we have, this is single ventricle. So the anatomy is different, but the common factor is a large ventricular septal defect and pulmonary stenosis, all of which leads to good mixing and reduction of pulmonary blood flow. And since you have less red blood flow coming to the mixing chamber, less red blood flow coming to the mixing chamber, in all these anatomical situations, there is more cyanosis, more blue ink in the final collecting chamber. Now, if you remove PS from tetralogy physiology, what do you get? You get increased pulmonary blood flow. Now, because of the mixing, the blood flow in the pulmonary circuit, which was restricted by the PS, is now no more restricted. And therefore, you have more blood going to the lungs and more blood coming back to the heart. And therefore, the heart is loaded and you have increased pulmonary blood flow with heart failure. And because you have increased pulmonary blood flow, the amount of red ink coming back is pretty good. And the ultimate reservoir is now not as blue as one would expect in tetralogy physiology. So you have little cyanosis and you have more heart failure. And this is what we call the transposition physiology. Although this is not a very correct term, as Dr. Tandon said, that he did use transposition physiology as a classification, but he went on to say that it is not a very correct term because you may not always get increased pulmonary blood flow in tetralogy, because if you have PS as was included in one of the 5 TDS, then the blood flow could be reduced. But most of the times in transposition physiology, the pulmonary blood flow is increased. And therefore, it is referred to as, all these situations are referred to as transposition physiology, because more commonly, blood flow is increased in transposition physiology. Now, what are the anatomical variants within transposition physiology? Once again, the mnemonic that I have used and I teach my student is 6 teachers in DAV college. And what are these 6 teachers? Tetralogy, DNL transposition, truncus arteriosus, tricuspid atresia, without pulmonary stenosis. With 5 TDS, they were with pulmonary stenosis. Here, they are without pulmonary stenosis. And even with pulmonary stenosis and tetralogy, if you have a lot of collaterals, these collaterals can increase pulmonary blood flow and load your ventricle and cause heart failure. So tetralogy with no pulmonary or mild pulmonic stenosis, and even tetralogy with increased collaterals. And then you have added the 6th T over here, and that is total anomalous pulmonary venous connection. S is for single ventricle, D is for double outlet, IN is for interruption aortic heart, and that is the hypoplastic left heart situation, AV canal defects, and common atrium. So 6 teachers in interrupted aortic arch, HLS, DAV college, D is for double outlet, AV canal defects, and C is for common atrium. So just to remember the different anatomical variations within transposition physiology, you have 6 teachers in DAV college. So tetralogy, 5 TDS, triology, PAT, and transposition physiology, 6 teachers in DAV college. So if somebody asks you what are the anatomical, you can tell them, or when you try to rule out everything, then at least you remember that this is what I need to rule out as far as the anatomical variation is concerned. Now, the clinical presentation is pretty different between transposition physiology and tetralogy physiology, but let's revise it. Everybody knows it, but let's revise it. Symptoms in transposition physiology will occur very early in the neonatal period because they are with heart failure and they are not so much with cyanosis. The cyanosis is mild, it can be severe at times, but because of the increased pulmonary blood flow, the cyanosis is mild. As compared to the early presentation, tetralogy physiology manifests a little later at 3 to 6 months of age. Then, as I said, there is a congestive heart failure situation because of the increased pulmonary blood flow, failure to thrive and gain weight, and the patient is only mildly cyanotic. On the other hand, tetralogy usually has a lot of cyanosis. So cyanosis is more marked here. Heart failure is not there. Cyanosis is less marked. Heart failure and failure to thrive with transposition physiology. No heart failure with tetralogy. And when you look at the X-ray, you find that there is a cardiomegaly with increased pulmonary blood flow on the chest X-ray in a case of transposition. In tetralogy of Fallot, there is no cardiomegaly and the pulmonary blood flow is in fact reduced. So there are lots of differences between tetralogy and transposition. The second heart sound we will discuss later, but cardiomegaly in transposition, we must remember, appears within the first, second, or third week of life. So early presentation, heart failure, little cyanosis, cardiomegaly as early as 2 to 3 weeks, and the X-ray shows an increased pulmonary blood flow, which is reversed in cases of tetralogy. Late presentation, cyanosis is marked, no heart failure, no cardiomegaly, and reduced pulmonary blood flow. And then we will take the last one, and thereafter, I think we'll sort of call it off for the day, and then go to the other things on the next meeting. Now, we know that once you have a left to right shunt, then there is a gradual development of pulmonary vascular obstructive disease. So as long as the pulmonary vascular obstructive disease is not severe, the shunt remains left to right, whether it is part of a simple ASD, VSD, and PD or a complex situation of transposition. And this is the Heath-Edward classification, often asked in the examination. In the first stage, you simply have this is a medial hypertrophy. In the second stage, you will have intimal hyperplasia. In the third stage, you will have fibrosis of the intimal media. And up to this point of the upper 2 stages, this is totally reversible. In stage C, where you have some fibroelastic tissue also being deposited in the intima, then it is partially reversible. But once you get to stage 4, and beyond, then this becomes an irreversible situation. So the first two stages are totally reversible. Stage 3, where you have intimal hyperplasia along with some fibroelastic tissue, partially reversible on surgery and intervention. But once you have medial thinning and you have plexiform lesions and you have necrotizing arthritis, I think you're beyond repair and no kind of surgery is going to reverse it. So up to the 2 stages, totally reversible, third stage partially, and beyond that, not reversible. So one should be aware of the Heath-Edward classification. And once you have pulmonary vascular obstructive disease, then you have a reversal. That is, you have a right to left shunt and the patient goes into a situation of Eisenmenger physiology. Eisenmenger presentations. Eisenmenger physiology in the presence of transposition physiology occurs very early. So if you don't intervene, by about 9 months to a year, these patients will go into Eisenmenger. The PDA, VSD, Eisenmenger, they have to be really large. The small PDA or a small VSD, ASD will not go into Eisenmenger. It is only the larger ones, PDA of 7 millimeter, VSD of 15 and ASD of 30 will go into Eisenmenger. Eisenmenger starts very early. In most of the PD and VSD, it starts in the first year of life, 80%. In ASD, of course, it starts very late. It does only in about 5 to 10% cases will it start in infancy. And the average age at which reversal occurs is 18 years for PDA, 22 years for VSD, and 35 years. And if you have a truncus type 1 and 2, then 100% of them will go into Eisenmenger because it is a large shunt. Then PDAs, large PDAs have a 90% chance of going into Eisenmenger. VSD is less, to about 50%, and ASD the least, in 10 to 20%. So these are the figures that you want to remember and should quote. And the last, we had said that there are 4 important causes of cyanosis. First was tetralogy physiology. Second was transposition physiology. Third was Eisenmenger physiology, all of the 3 which we have discussed. And last is the triology physiology, which you said was intact ventricular septum with pulmonary stenosis, and the associations were PAT, pulmonary atresia, and pulmonary and pulmonary stenosis. So PAT, and this is what we have in triology of fallow. Triology of fallow, the ventricular septum is intact. The pressure in the RV goes to suprasystemic, RA pressure increases, and then you have a reversal of shunt either through the PFO or through the ASD, depending upon what we have. So with that, Mudit, can we stop here, or what do you want me to do?
So that is fine. If you think that we'll be able to take up the same thing in the next session, that will be more.
Yeah, I think
so
we can take the examination. This was only the initiative part of Cyano, because often what we do is that we jump straight to the diagnosis of tetralogy and transposition and everything, and then we don't understand some of the basics which we should understand. I thought that let me dedicate at least 1 hour to discussing some of the very basics of cyanotic and heart diseases.
Yeah, that is fine.
Then go on to the So
probably this week residents can also go back and read the initial chapters of Tandon, and that will further consolidate and help.
Because it's something which they don't generally read, and they just don't, they just jump to. So I thought let me stimulate them to read about this, and then next Thursday perhaps we can do the rest.
We can go on
the whole thing.
That will be
because that is something which everybody already knows. It's just basically a revision. Everybody knows about the X-ray, the ECG,
and to be very candid with you, that is also one of the things that they look forward to.
Obviously, I mean, so I thought that let me just make a basis, because admixture lesions, children tend to get confused, and then where the shunt is occurring, and then how do you calculate bidirectional things. So it stimulates them to read some more. And then we can take up the questions next time when they come for 5 initial minutes.
That will
we can take up the questions and then go on to the history and physical examination.
That will be perfect. I think my colleagues, Dr. Sumod, Dr. Arima, and Dr. Girish, will be having all 3 of them next time also. And as you have said, that probably we'll keep the questions for the next time, as you have suggested. And in the meantime, you all are now at least charged up to read this thing. And I think once you read Tandon, you'll be getting more clarity about these diagrams and these things. They are given very nicely, descriptively there. But a few comments are invited from our chairpersons also, Dr. Girish, Dr. Arima, Dr. Smooth. Any suggestions, any comment from your side? Very happy. Anything particular, Girish? Anything, Arima? Yeah, Arima, please, anything.
Sir has told so many books to the students, suggested so many good books to the students to study. One article I would also like, which is a very classical article, that is article from Paul Wood. That should be read by everyone about Eisenmenger. And that is a very good article, and that summarizes everything. So next time when you are coming prepared, not only the books sir has suggested, that article is also important. And another thing in that, the study, the hyperoxia test, one thing I would like to emphasize, that it is not the oxygen saturation which is measured, it is the partial pressure of oxygen which is done by the ABG. That should be taken, because fetal hemoglobin leads to a problem in the interpretation of the test. So you should know that.
Yeah, ideal. I totally agree with you. The ideal thing is to do an ABG, but the books also go on to say that if you do not have ABG available, a 10 to 20% rise in saturation can also give you a good impression. So, but ideally, yes, I agree, it has to be ABG. And as very rightly pointed out by Dr. Nigam, the students should go back from the textbook, they should go back and read the original articles. So when we were students about 40 years back, we were always read the book by Paul Wood also. Now it's not available to very large number of to our students, but we read the original Paul Wood. And I'll always encourage the students to go back and look at those original articles and get an information from them, because basics always come from the original articles.
So that's a great suggestion, Dr. Arima. I'll be posting this original Paul Wood article for your reference in all the 7-8 groups that you all are there, and you can definitely go through those articles. Tandon book is easily available. So we will catch up next time. If you have any suggestions or comments, you are very happy to write them to us, and we must thank sir for presenting a very comprehensive initial introduction today. And we'll catch up and continue the same topic, approach to congenital, cyanotic congenital heart disease next time. And I wholeheartedly thank you, sir, for giving us this opportunity to have you again on this wonderful platform. More than 280 people are today live with us. And
but I hope they were, they sort of appreciated. They were not bored, because they probably must have come expecting some clinical discussions, more of a clinical discussion, and then we had this theory part going.
So that's the beauty of having the topic. Every teacher present their own perspective, and that is how you get to know everything. And I think that once you get an idea of everything, you read it from the book and then consolidate and make your own concise approach towards that.
So next time it will be a clinical situation.
Clinical question.
This time I thought that let's build up something.
That is very, very perfect, sir. And thank you so much, everyone. And you must join next time. We have specifically requested sir to be there next week with us, and we'll continue this discussion. And you'll get what you really want to hear. What is the approach? What is adult and what is child of? What are the common questions of top? What are the excesses? Everything, the common things, common approaches. We'll have next time. Thank you so much, sir. Thank you, Intas, for providing us this platform, and we'll catch up next Thursday, same time, and continue.